So I wanted to suggest that there are some lessons that we could learn from history, because the problem that you alluded to, which is that the assessment of the effectiveness of a therapy which is not predictable, oral appliance being perhaps one that we have the most experience with, but even the others, there's a problem of cost. And I would like to suggest that the institutions like the SRS and the ASM and the European equivalents to those and some of the other country-based associations could play a role here. So when we had CPAP, what was done was we had a titration, and the effectiveness of the treatment was evaluated right then and there with a second night or a split night study. And it took a while, but eventually the payment agencies, Medicare being the model, but many of the others followed, basically set up 3 levels of payment for the evaluation and treatment of sleep apnea. There was a diagnostic payment for a sleep study. There was discussion and eventually some agreement that you would pay for an evaluation study. And then there was the payment for the device and the long-term maintenance, which a few years back was evaluated at 3 months, and they decided whether you would continue paying or rent it for the first part. So there was 3 pieces to the treatment. I think we should learn from that model, and we should be thinking about how to do that in the reversible forms of therapy, mostly devices. So obviously you can't do that for surgery, but you can do it for an oral appliance. And I haven't heard too many models that separate it into those 3 levels. The first being proof that the person has sufficient disease. The second being payment for the evaluation that the treatment actually works, separate from long-term maintenance treatment. And that again is a little complicated in that you kind of pay for the device up front and then use it. But there are ongoing costs which don't necessarily need to be approved. We've all had experience with patients who've had an oral appliance fitted, and we know it doesn't work because we've done a sleep study that shows no change whatsoever, but the patient swears that it's good and wants to continue using it. And I think that, the payment agencies have the right to demand some evidence, either that the AHI goes down or that some metric such as sleepiness goes down or some other proof that this is worthwhile. And along with that comes the issue of adherence. It costs money to put an adherence monitor into an oral appliance. We try and do it, but we are often stymied by the fact that that's basically not possible if nobody's willing to pay for it. And I think the society should take the position that they require evidence that something works and evidence that it's used as sort of non-negotiable to payment for that device. Patient wants to use something that we can't say works, that's always their prerogative. But if the society is going to pay for it, if the insurance company is going to pay for it, we need proof. That standard probably needs to be pushed for our societies. And we should be saying, look, we want payment for evaluation. We want payment for judgment of adherence wherever that's possible. It's now possible for oral appliance. And if another device comes out, a position, enhancing treatment device, which are out there but not used very widely, the same should be required. People must use it to have it paid for. People must show that it works before we'll consider it. And those 3 payments by the third parties should be separated. It shouldn't just be, if you have sleep apnea, we'll pay for an oral appliance. There should be a gradation. And I think that would help enormously in implementing it. I'll stop there. So I wanted to come back to this issue of evaluating oral appliances before paying for them, or separating the payment for the oral appliance into an evaluation phase, which I advocate for. And the issue of the boil and bite was kind of mentioned and dismissed. I think you have to be careful not to throw out the baby with the bathwater. For hypoglossal nerve stimulation, we were successful in getting the payers to approve an approach that was justified, which says we're going to have this relatively expensive procedure, the DICE procedure, where there's an anesthesiologist and an OR, and I don't know what it costs, but it's not cheap, before we will authorize the placement of the device. And if you look at that literature critically, It is predictive, but it's not perfect. And yet we accept that it's good enough. I would suggest to you that the boil and bite, or the what was until recently available, the matrix titration device, made a prediction, and it was not perfect. But in fact, I think it was probably pretty good at, making an improved chance of success. Certainly, if you have a boil and bite and you have absolutely no benefit, I think that that can be taken as a sign that this is going to be a difficult patient where you might want to consider a more aggressive push of another therapy, such as CPAP. Whereas if it's dramatically effective, but not perfect, you might want to say, well, I think I can do better with a definitive device. This should be paid for. And I would suggest that we should take the same approach, not throw out a treatment or an evaluation procedure just because it's not perfect, but rather push for the idea that it stratifies the need for reimbursement. So I would argue, if I was making a pitch to Medicare or CMS, that they should pay for an evaluation with a disposable, or they'll put forward a relatively low reimbursement so that the dentist is encouraged to come up with a way to decide how the patient will respond. And then a separate payment, an additional payment, if it's successful, and no further payment until the dentist submits some kind of now literature proven therapy that it is an alternative. I think that would make an enormous difference in the number of people who were evaluated for and therefore shown to be effective, as well as the people who were not given oral appliances and pushed back towards CPAP. And it would solve some of the problems of, which therapy do you go with first? It would allow people to evaluate and triage, rather than saying, well, boil and bites don't work, or the matrix therapy isn't available anymore, but some other form of that may come out shortly. And you would use that and say, well, that will triage me and give me an 80% chance of success instead of a 30 or 40 or 50% chance of success with my oral appliance. And that's what I'm going to pay for.